All attendees are in listen-only mode.
Hello and welcome to the Emergency Care Improvement Programme Safer, Faster, Better webinar series, covering the key principles from the Safer, Faster, Better document and how these can be applied within your own systems. Today's webinar on running safe, effective wards will be delivered by Gordon Caldwell, Consultant Physician at Western Sussex, and Pete Gordon of the ECIP team. However, before we start, there's just a few simple housekeeping points. Number one, the session is being recorded and the recording will be available to view on the ECIP website shortly afterwards. Number two, all attendees will be muted during the presentation to avoid any background noise during the recording. Number three, at the end of the presentation, there will be an opportunity to ask questions. If you have a question, please use the raise your hand option in the panel on the right-hand side of your screen, or if you don't have audio enabled, you can write your question in the question section of the panel. During the Q&A, we will then either unmute you so you can pose your question in person, or if you don't have audio, we'll be able to pose the question on your behalf. Okay, so I will now hand over to Gordon and to Pete for today's presentation. Thank you.
All right, thank you. So thank you for asking me to talk about my experiences in striving to run safer and more effective daily clinical reviews on ward rounds. I'll start by telling you some stories of how easy it is for things to go wrong during inpatient care to emphasize the importance of ward rounds. So this man had been treated successfully for pneumonia, but his cannula was left in after the intravenous antibiotics were stopped. And the day he was due to go home, he showed me this lesion on his left forearm, which is an infection at his cannula site. That had caused the septicemia. The septicemia was with a methicillin-resistant Staphylococcus aureus, and he had to spend an extra 4 weeks in hospital because of an error of omission of removing his cannula at the right moment. This case is a case of misdiagnosis, so another patient who was treated for pneumonia, although when his daughter admitted him to hospital, she was concerned he might have had a deep vein thrombosis. That information was given to the A&E staff nurse, but wasn't transmitted through to anybody else in the hospital. This was a New Year's Day post-take ward round, and he was reviewed on the post-take ward round by a consultant in chest diseases, who also reviewed him 2 days later. Now, she made a diagnosis of community-acquired pneumonia down at the bottom of the right lung, and he was seeming to make good progress on his intravenous antibiotics. But he was transferred up to my ward, and I continued with the treatment for pneumonia. 2 days later, he collapsed with a massive pulmonary embolism, which was confirmed on a CT pulmonary angiogram. So he'd had a deep vein thrombosis and a pulmonary embolism, and he died. Now, in this case, neither the respiratory physician nor myself had ever seen simultaneously the X-ray, which showed a small area of pneumonia, the blood gases, which showed profound hypoxia. And if we'd seen that combination, I think we'd both have decided to treat for pneumonia and pulmonary embolism and arrange a CTPA. This was during a very busy New Year period. We'd been under a lot of pressure to discharge patients, and we were all seeing more patients on our ward rounds than we're accustomed to. So in this case, the pressure of work, poor integration of clinical information between paper and multiple IT systems, coupled with the problems of continuity of care and the pressure of working, results in a misdiagnosis and possibly an avoidable death. This is a more recent case illustrating multiple system failures that were affecting daily clinical reviews. This lady, who was in her early 70s, had been treated earlier in the year for a lumbar spine abscess. She had 14 or 16 weeks of intravenous antibiotics, and as far as we knew, the lumbar spine abscess had been resolved. She returned to hospital with cellulitis of the legs, and 2 days after admission, she suffered an anterior myocardial infarction. And this was on my ward, and I assumed the next day that when she'd left my ward that she'd gone to coronary care unit, which would be the appropriate place for a person with an acute anterior myocardial infarction. But in fact, she was transferred to another medical ward for an unexplained reason. And in our hospital, when you change wards like that, provided it's another medical ward, the next team takes on the patient's care. On that ward, she complained of pains in her chest and back, which were attributed to coronary thrombosis. Over a period of 8 days, she developed spinal cord compression, and this MRI scan is showing spinal cord compression. She developed spinal cord compression from a new abscess higher up in her spine. That abscess progressed and caused permanent paraplegia. Now, during those 8 days when she was developing the permanent paraplegia, she was never reviewed by the same doctor on consecutive days and came under the care of 2 different consultants. Her vital CT scan, which would have shown the abscess, was delayed by 4 days. So multiple system weaknesses resulted in a lady developing a permanent paraplegia that was possibly avoidable. So my purpose in showing those 3 stories is to emphasize how vital the daily clinical review is to the progress of a patient and to the safety and appropriate care for the patient. So the errors that I highlighted, I think, could have been avoided by more reliable clinical reviews on ward rounds. As doctors, I think we can be poor at describing our work. This is what I call the clinical care cycle. The first step in clinical care is to try to make diagnoses in the context of the patient's comorbidities. This is a complex process, and again, as doctors, we often fail to explain the information we need for making a diagnosis, the amount of time we need with the patient, being undisturbed whilst we're taking the history and examining the patient. And it's a complex process which you'll all appreciate is done at great speed. We then recommend treatment plans and deliver those treatment plans whilst monitoring the patient's progress. That will be with the vital signs, blood tests, clinical review of the patient. Then the review of the patient's progress is crucial, and this is the daily clinical review usually done on ward rounds. Is the patient getting better or worse? If the patient's getting better, is it by good luck because we've given an antibiotic which both treats pneumonia and a urine infection, and so we're fortunate we've just got the treatment right? Is the patient isn't making the expected progress? Why is the progress not being made? Have we got the diagnosis wrong? Are the treatments not being given? Are we not monitoring the patient properly? Has some new event developed that set the patient back? So if you're a manager and you're looking at that and wondering about the clinical care cycle, you'll see that that's pretty much a plan, do, study, act quality improvement project that we do with every patient. So you've seen that the daily clinical review is crucial to the management of patients, the progress of patients. And you'd have thought then that in the same way that hospitals measure outpatients and theatres and clinical procedures, that we'd be measuring ward rounds, because you can't manage something if you don't measure it. If you're a manager, again, you may be looking after several clinicians who've got 2 or 3 sessions in their job plan each week for their daily clinical reviews, and yet we're not measuring them, working out whether they're reliable and working out whether they're effective. So that suggests that somehow we don't think ward rounds are important. And if we're not measuring them, then we're not going to be able to improve them. This picture, which unfortunately isn't animated at the moment, is meant to show complexity and reliability. And I think clinical care has now become highly complex. When I started off as a doctor, most patients seemed to have a single clinical condition, pneumonia or diabetic ketoacidosis, and we could measure the outcomes and the performance. But these days, most of my patients have 4, 5, 8 important clinical conditions simultaneously, and the care has become highly complex. Yet we still measure outcomes as if it's a single disease process. For example, I was talking quite a bit about pneumonia just now. A patient with pneumonia might well have cardiac failure and chronic obstructive pulmonary disease as well. And one clinician might code that as pneumonia, whereas another might code it as cardiac failure and another as COPD. And yet we're measuring outcomes depending on those clinical conditions as if we can distinguish which is the primary condition. But if we're dealing with a very complex process, I think what's important is that each component is very reliable. So if you imagine in the middle of the slide there, there's a nurse who's very reliably giving intravenous antibiotics. So she's giving the right dose at the right time, the right route to the right patient. But somebody has to inform her when the right time is to start giving those antibiotics. Somebody has to inform her the right time to stop. And microbiology have to influence that as well. So in a complex system, each component has to work very reliably and has to have very flexible communications with the other parts of the process. So coming back now to think again about ward rounds, how would we know that a ward round process is reliable? In 2009, one of my year 1 doctors led all the patient reviews on the ward round under my supervision and asked me, did I do it all? And I think that was the first time I'd thought of what doing it all might be on a ward round. So 2 days later, we discussed our thoughts on doing it all, and 4 days later, we prepared a checklist to support managing complexity and reliability on the ward rounds. So the definition of our checklist has helped us to define a process. And until then, I think our process was good luck and crossing our fingers. The process that we have now is that we identify how many new patients we're going to see on the ward round, how many review patients, how many doctors there are on the ward round, the number of wards we're going to have to visit. So we define how much work we've got to do. We keep this on a piece of paper because it's really easy to hand the piece of paper around and to modify it and change it quickly. The process of our patient reviews, we review the list of diagnoses that we've put onto the computer these days. We check incoming results. We think through the case, have we got the diagnosis correct or not? We make a decision at some stage during this process as to whether we think the patient's very clinically frail and wouldn't be appropriate for intensive care treatment or cardiopulmonary resuscitation. We document our interactions with the nurses. At the bedside, record again whether the nurse is with us, go through the usual procedures of cleaning our hands, introducing ourselves, checking we're talking to the right patient, and asking the patient and listening to the patient. We then make sure we've recorded the vital signs, look at all the medications that have been prescribed. If the patient's on intravenous fluids, review that. If they're diabetic, review their diabetic control. Make an active decision about what tests we're going to do, active discussion about discharge arrangements, and record whether the patient's ready for discharge. We then do a 7-point safety check on every patient every day, asking the patient specifically about pain or discomfort, eating and drinking, bowel function, urine catheter, intravenous cannula and lines, pressure area care, and whether we should change or stop the VTE prophylaxis. The notes are signed by the consultant. We sum up to the patient and report the plan to the nurse. So we've got a very clear process. The statistics on this, until up to the middle of this year, I led 361 what are called post-take rounds, where you see emergency admissions, and that was taking about 15 minutes per patient. On the routine rounds, where you're seeing patients who've been in hospital for a day or two already, it was taking about 12 minutes per patient. The statistics in more detail, which you can look at later on, because this is being recorded, the real reason I've shown this, two real reasons. One is that the nurse at the bedside, which I think is crucial to communication about the patient care and shared mental models, has unfortunately dropped progressively as the years have gone by, down to 10% this year on routine rounds. And a similar drop has been seen on our post-take ward rounds as well. I think the nurses are simply too busy doing basic care for the patients to be able to be with us on the ward round. And the other point to raise there is that we introduced electronic prescribing in the middle of this year. The time taken for patient review increased by 3 minutes the day we introduced the electronic prescribing because of the difficulties of using the software in the clinical situation. We didn't have enough hardware, and the software was quite difficult to use as well. Now, the lessons I've learned from this is that because of the complexity, measuring outcomes is almost impossible. A simple example, if a patient's admitted with a diagnosis of community-acquired pneumonia, for one patient, full recovery will be a good outcome. If another patient has metastatic breast cancer and community-acquired pneumonia, a calm end of life might be a good outcome. So measuring outcomes is almost impossible. I think the reliability of the individual components is paramount, and the communication between the components very important again, and our communications with nurses very weak at the bedside. Shared mental models really matter. Do the doctors, the nurses, the physios, the pharmacists, the patients, the relatives, the GP, all have the same idea about what's going on with the patient? Being organized is better than not being organized, and at least our checklist helps us to be organized and to define the process. I'm sure our patients feel more confident and staff feel more confident as well. But proving that I've reduced hospital-acquired infections, reduced DVT problems, that I've reduced length of stay is really difficult. Through doing this work, I've been able to identify a lot of factors that have a negative impact on efficiency. And again, if you're from a management background, come down to the ward, see how we work. There's lots of things that you could do now that would make ward rounds more efficient, more effective, and more safe. Having patients on multiple wards is definitely counterproductive. Having lots of consultants on one ward is counterproductive. interruptions really disturbing and can lead to misdiagnosis, mismanagement. The noise on our wards at times is almost unbearable, and that affects concentration. Most of our wards these days, I think, have inadequate space at the bedside to get all the doctors and all the kit round the bed. As I said, there's a lack of nurses available to communicate with at the bedside. Our paper notes are disorganized. We have notes for doctors, nurses, physios, OTs, social workers, all in different places. Quite often our charts are incomprehensible. We put a lot of information onto them, but they don't transmit meaning back to us. Sometimes our patients aren't ready to be seen. Often the IT hardware we've got a shortage of. The software can be very difficult to use. At times we have too many patients, not enough doctors, there's little confidentiality, difficulty of tracking results, and speaking to each other can be inadequate as well. So I think that one of the problems with ward rounds is they're so ordinary that we don't notice them. And the danger with things that are ordinary that we don't notice is if they're ordinary and wrong, it soon becomes ordinary and acceptable. So if we have to see 25 patients on 6 wards subject to constant noise and interruption with poor software and hardware and just shrug our shoulders and say that's what you expect in the NHS, we'll end up with misdiagnosis, mistreatment, prolonged length of stay, and as you've seen from earlier on in the presentation, occasionally with deaths as well. So I think ward rounds are essential processes, vital to the care of our patients and to the safety and satisfaction of our staff. So let's cooperate, clinicians and managers, to improve this everyday, highly complex, ordinary, but ignored aspect of clinical care. Ward rounds are a vitally important theatre of operation. So if you want to see better, swifter, safer outcomes with improved patient and staff satisfaction, then exert effort on improving the reliability of ward rounds in your hospitals. Thank you.
Thanks ever so much for that, Gordon. Can I now hand over to Pete Gordon of the ECIS team to take us through his presentation.
Yeah, thanks very much, and thank you for that talk, Gordon. That was great. I love the phrase, so ordinary we don't notice them. And I'm phoning from a hospital site as I do this call, and I can spot all the things Gordon has talked about. So I'm going to follow the talk now by talking about why we need simple rules to manage urgent and emergency care. I'm going to talk about that. Will include something called the Safer Patient Flow Bundle. And I'm going to just start off by talking about why urgent and emergency care is so important. If my slides move. There we go. So when we're looking at the evidence around urgent and emergency care, it's really important that we phrase it in the right way. So here we've got 2 articles of research. 48% of people over 85 die within 1 year of hospital admission. 10 days in the hospital, that could be an acute or in a community hospital, leads to the equivalent of 10 years aging in the muscles of people over 80. So you could phrase that a different way. If you had 1,000 days left to live, or your loved one, I always talk about my mum, how many days would you choose for them to spend in hospital? When we look at, what the problem is, and we have really high levels of bed occupancy, and when we look at some sites where they've managed to reduce that, so this is a study in the BMJ from Derby, and what they've proved is that if you do, all the things that we know work, and you reduce mean bed occupancy, there's an associated reduction in all markers of mortality and an improvement in 95% performance. One of the key messages that I'd like to get across is that hospitals are not a place of safety for people that are medically stable and ready to be discharged or moved to another place. And that's really important. This slide's from one of the clinicians we've worked with before called Dr. Richard Jennifer, a great guy. And when he presented it really struck me. And I think that's important in our minds that we realise that hospitals aren't a place of safety. When I trained as a a nurse in the 1980s, we believed that hospitals were a place of safety, but it's important we realise that they're not for people who are ready to leave. Another key message for us in ECIP is that people often talk about beds being capacity. So one of our key messages is that beds aren't capacity. Beds, we need beds, but beds are where patients wait for the next thing to happen. Capacity is permanent doctors, enough nursing staff, not an over-reliance on bank and agency staff, support from AHPs, diagnostics wrapped around the patient. So a key message from us. Now, I'm going to talk about the simple rules for urgent and emergency care. And so one of the things I'd say to you, listening in, is there's a difference between complicated rules and complex rules. So on the left-hand side of your screen, you've got putting a man on the moon, and on the right-hand side of your screen, you've got somebody raising a child. And if I was to say to you, is putting a man on the moon the same in principle as raising a child? They're not. One's complicated and one's complex. When we're thinking about urgent and emergency care, we need to realise that it's a complex, adaptive system rather than a complicated system. So using complicated rules doesn't work. So moving to my next slide, just to try and illustrate this point slightly in more and maybe a little bit of humorous detail, you've got a picture of a car on the left, so that is complicated, and you've got a picture of a flock of starlings on the right-hand side. So the picture on the left is complicated, and the picture on the right is complex. Now, the people who designed this car, using complicated rules, tried to analyse why the starlings flocked, and actually they couldn't work it out. So what I did is I spoke to these starlings, and I said, well, what do you do? And they said, well, this is what we do. We follow simple rules, and we only follow 2 simple rules each day, every time we flock. And those rules are, we fly as close to each other as possible, and we always fly as close to the centre, and that's how we flock. And I said to these starlings, well, that's fantastic. I'll take that back. And as I was leaving, they said, and do you know what? If you follow simple rules each day, every day, do you know what you don't need? You don't need a flocking manager. Hopefully someone will laugh at that joke. So, moving onwards, simple rules work, but the key is with urgent and emergency care is you've got to do them each day and every day, and variation really is a huge problem, and that could be variation between shifts, that could be variation between wards and departments, variation between services. And so I'm just going to give you a couple of examples of some simple rules which you could try in your hospitals each day, every day. So the first one is red and green days. So this is really simple. So a red day is a day that is of no value to a patient. So this could be a patient's journey, and a green day is a day that adds value to a patient. So if you say to me, and I'm one of your patients, you are going to have a CT scan today, which you need, and it happens, that would be a green day. If you say you're going to have a CT scan and it doesn't happen, that would be a red day. And I'm sure you could think of much of these. But this could be a typical patient's journey. They come in to the AMU, then they go to another ward, and then actually they pause and nothing happens. And so one of the things we'd recommend people do is try really giving a bit of thought about how many red days you have for your patients and how many red days you're planning to have for your patients. There's lots of ways you can do this. You can measure it, you can visualize it. For us, really, is when you do your ward rounds or board rounds, however you do it, is to say to yourself as a team, how many red days are we planning for this patient? So when it comes to this Thursday or Friday, when you're going into weekend, how many red days? So that's one technique, a simple set of rules. And the other one is something called the Safer Patient Flow Bundle. So those people who come from a clinical background will be familiar with clinical care bundles. I first came across this when I was a senior nurse for critical care, and someone said, have you heard of the ventilator care bundle? And I said, no, sounds like some new modern fandangled set of rules. And what I learned is actually if you follow these rules each day, every day, actually the patients improve. So this is the Safer Patient Flow Bundle. And, you know, when you're listening to this, there won't be anything new here. But when we've seen this adopted by sites, and they sometimes localize it slightly, we do tend to see a noticeable drop in length of stay. So the S is that all patients should have a senior review before midday. And if we could photocopy Dr. Gordon Caldwell, around the country, I think we'd be doing okay on that. So I'm not going to concentrate too much on that because Gordon has covered it really well. The A is that all patients will have an expected discharge date, but there's usually a circular debate around this because there's lots of inbuilt delays. We'd say it really simply, do all your patients, can they answer, or their loved ones, answer 3 questions. Do I know what's going to happen to me today? Do I know what's likely to happen to me tomorrow? And do I know, in my words, what I need to do to leave hospital or to be transferred? So that's the A of the bundle. The F of the bundle is the flow of patients will commence early in the day. So these are particularly those medical wards that routinely probably have 2 or 3 discharges every day and routinely take patients from the acute medical unit. And what we'd say is what we typically see, we see in a hospital, we see EDs beating very fast, acute medical units beating fairly fast, and we see flow really slow down as you get into inpatient ward land. I may be generalising a bit there, but overall that's the picture we see in ECIP. So what we'd say to those wards is each day, every day, is you pull your first patient before 10 o'clock to create the space at the front door for the predictable flow of patients that will come from GPs or through the emergency department. It's quite difficult to do, but bearing in mind how dangerous having a crowded emergency department is if you do this correctly, it makes a real difference. The E is earlier discharge. So for this one, we're not even saying 50% out by midday, but usually, typically what we see is if you can get about a third of your patients out from the base inpatient wards before midday, flow tends to improve. And the biggest constraint there is typically TTOs and letters. And we know it's an older problem, and it depends on having enough resource there and so on and so forth. But where wards do that and they really crack that one, they tend to be able to get the earlier discharge. The key is getting it right across a whole set of wards. And the R is often where an acute hospital needs a bit of help from its partners, and that's the review of every patient who's been in hospital for a set amount of time. So on this slide it says 14, but we have a lot of clinicians in ECIP, and I think of one who springs to mind at the moment, Dr. Ian Sturgis. He would say, that should be 7 days. It might even be less, and we would call those patients stranded patients. And so, I imagine that a lot of your organisations will have a meeting room where people discuss what's going to happen next. We'd say do that really at the ward level and provide the likes of Gordon and his teams real support to think, actually, what can we do to make sure this patient moves safely to the next stage in their journey. So, for example, I'm in an acute hospital as I speak to you, and we're doing an event to try and reduce the number of stranded patients, and actually, there's an awful lot of inbuilt delays. So, for example, we're going to plan to do a DST next week. And, our question would be, can you bring that date forward? Have you really sat down and spoke to the family? And when you really do a proper forensic MDT focus on these stranded patients and you reduce that number, we tend to see great benefit. So so if you can complete all 5 elements of that, with limited variation, you won't be able to get it right every day. What we tend to see is, if I can get the slide to come up, what we tend to see is great improvements in length of stay. Let me just get the slide. And we tend to see something like this. So this is a couple of medical wards from a trust in the sort of middle of the country, and if you can sort of see where the step change is. And actually what they did is they had a real sort of rapid focus on implementing the safer patient flow bundle, and you could see that, that distinct decrease in length of stay. Okay, so that's me done talking about simple rules, red and green days, and the Safer Patient Flow Bundle. There's a document there called Safer, Faster, Better on your screens. One of the things that we think it's a great document because what it does is it covers the whole pathway for urgent and emergency care, before hospital, in hospital, and outside the hospital. So one of our big tips in ECIP and part of the ECIP program, Emergency Care Improvement Program, would we recommend you download a copy of that and read it. Okay, so that's me finished, Emma, so handing back to you.
Okay, thank you ever so much, Pete, and thanks again to Gordon as well. Both of you, absolutely brilliant. That was great. If anybody on the line has any questions, then please feel free. As I say, you can either use the raise your hand option, and my colleague Paula can unmute you to ask your question to Pete or Gordon, or both. Otherwise, if you've not got audio, if you type your question in, then Paula can read that question out for you. I'll just give people a moment or two to get used to the technology. Paula, do we have any questions waiting at the moment?
No, nobody's raised their hand at the moment. I can't see anybody's popped a question up at the moment.
Let's just give people a moment or two then to type something in.
Can I ask Pete then how, it's Gordon here, can I ask Pete how you've managed to get the wards to get that flow going earlier in the day? Because it does seem to me that sometimes patients are left waiting for a doctor to decide they're all right to leave, for example, the emergency floor or acute medical unit and go up to the ward, or up on the wards they're waiting for the doctor to finally say the patient can go home, when my habit these days is more or less to say on Tuesday, right, you're going home first thing Wednesday morning, and then you come in at 11 o'clock to get to the patient at 11 on Wednesday morning, and the nurse is saying, oh, we're waiting for you to say yes, it's all right for the patient to go home. I said that yesterday.
Yeah. So, I mean, that's a really common problem. And when we tend to implement the bundle, what we tend to do is take about 2 or 3 wards and work quite closely with them to start with. And we give a couple of examples of that, Gordon. So I'll give you an example which is a bit close to home to me. So my wife is a Band 5 staff nurse, and she works in the day surgery ward. So when I was in general management, it was one of the patches I managed. And actually, if you were to say to those nurses on day surgery ward, how many patients do you discharge a day? They discharge all the patients. And actually, and if you said to them, where are your governance procedures or policies or protocols, they don't have them. It's just the way they do it. So in terms of building that confidence up, I think that takes a while, but I guess the example of day surgery shows that it's possible. What I would say, and it's a really common problem, is from when I was practicing nurses, the amount of distractions for nurses and the burden is quite significant. So it's probably not quite as easy as making it an out to be. The trick is actually what we try to do is we say your shared purpose is actually we want to reduce the delays for patients, and patients who no longer require acute care, do we all sign up to that and agree that? So I guess that would probably be my thoughts on that in a rather roundabout way.
Yeah, it just seems to me that we can get, if we get things moving earlier, so by the time we arrive on the ward, do the ward round 8:30, 9 o'clock, the patients have already come off the emergency floor, then they get seen properly that day and would be moving well ahead of the game. And you say probably needs some fairly intensive work between the emergency floor and the wards and the discharge lounge to facilitate all that. Yeah.
Absolutely. And I think from our point of view, we'd say earlier is always better, because we know we always have a hump of stuff that happens at about between 4 and 6 o'clock, and the effect on patients moving is, I mean, they're moving, during, late evening hours, and the risks of poor placement and those type of things are quite high.
Yeah.
When we've implemented the bundle and we get the wards, when they're pulling properly, not just pulling randomly, but what we do say to the wards is to pull the right patient. So sometimes we hear people saying, oh, you're going to let them cherry pick. And we'd say, do you know what? If you're using senior nursing staff and medical staff, they can pick the right patient. But yeah, earlier is always better.
Yeah, I mean, that's really important that the patient gets to the right ward. And so if they've got a patient with a gastrointestinal hemorrhage, that patient is pulled into the gastrointestinal hemorrhage, into the gastrointestinal service. And the patients of mine with bad diabetic feet come to my ward because the delays that follow on from the patient being on the wrong ward are really significant. And I think that's sometimes not appreciated by non-clinicians. They think that as doctors we're all just as good at looking after any medical condition, but actually it's once you're into the processes. So when we get gastrointestinal patients on our diabetes ward, we're very good at doing things like giving them breakfast on the day they're having their endoscopy, and that can delay their care by a whole week until the next endoscopy slot comes up. So being pulled into the right ward is really important.
And the same goes for nursing staff, I think, Gordon. So anyone who says a nurse is a nurse I think is probably wrong, really. So nurses tend to be much more comfortable looking after their own specialty.
Yes, I should have said pulled into the right team, because it's the team of doctors and nurses providing the care for the patient and dealing with what they're familiar with, who can deliver the best, most effective care for the patient.
Yeah, agree.
Thank you both. Can I just ask if there are any more questions from those attending at all, please?
There's nobody putting their hand up at the moment, Emma.
Okay. What I might do then is if I draw the webinar to a close, if that's okay. What I will say, though, is that if anybody does have any questions that they want to pose to either Gordon or to Pete, then please feel free to email them in to us at ecipinfo, all one word lowercase, at nhselect.org.uk, and then we can pass them on as appropriate. Gordon has also kindly put together a presentation with notes. So as well as the webinar that we've recorded today, we will also pop on the website the notes that Gordon has kindly provided alongside his slide set, if people would find that useful. So just a quick reminder from me that, as I say, the recording of the webinar will be available on the website very shortly. Thanks once again to Pete and to Gordon for taking the time to join us today for what were a couple of excellent presentations. Thank you ever so much for those. And we will see you all at the next Safer, Faster, Better webinar presentation. Thank you very much.
Thank you.
Thank you.